On today's podcast, a doctor and scientist who's been helping steer Canada's public health system through new diseases like SARS and COVID, and through an evolving revolution of data-based healthcare. Dr. Vivek Goel joins me to reflect on the wins in his long career as a scientist and academic, and his worries as science-based traditions of public health come under fire on social media.
We wind up having individuals trying to make choices in the face of that misinformation. And the trust in public health has really been eroded over the last few years.
Dr. Goel is wrapping up a long tenure as chair of the board of directors at the Canadian Institute for Health Information, having helped expand CIHI's gathering and analysis of data over 17 years. He's also chaired a federal expert advisory panel calling for an end to all of the barriers that prevent health data and information from being shared more widely. Roadblocks that he says are stopping Canada from becoming a health information powerhouse.
We should be able to do that in Canada. That would be the vision I have for the future. You have to bring data together from so many different systems. And if we were able to do that, we would outshine any other jurisdiction in the world.
Welcome to the Canadian Health Information Podcast. I'm Avis Favaro, the host, and this conversation is about reflections and advice from a public health leader who knows there's unfinished work on the road to getting Canadians the health system they deserve. Dr. Goel, thank you so much for joining the podcast.
Great to be here.
So you have had a long and amazing career, both in medicine and public health. It's a career that's anchored in data and evidence before it was sexy.
That's right. Yeah.
What is it about data and public health and the connection that drew you to this field?
It really goes back to even before I got into medicine. I was interested in computers and their application in medicine, and that's what got me excited. And one of my first sort of projects involved using decision modeling to predict outcomes or actions that clinicians could do. And one of the things I quickly realized is you can't really do the modeling if you don't have the data, right? The underlying data on disease progression, outcomes, who gets it, who gets better. It's been really exciting to see what's happened over that close to 40-year period, because we've gone from this era of having very little data to almost having too much data now, and we don't know how to work with it.
Is it possible to have too much data?
Some people will tell you can never have enough data, and certainly as we get to AI models, they need lots and lots of data. But you can certainly not have the right data, right? You can have lots of data, but they're not informing the questions that you have in front of you.
So was there a moment in your early medical career where the issue and the importance of public health grew in your mind and your heart as you said, I'm going to go forward in this direction?
I would say, just after completing my training and my internship, I went out into practice for a little while to see what it was like. And I was doing primary care and emergency room work. And I kept seeing people with conditions that I could see could have been prevented.
Like diabetes?
Diabetes or injuries. And so that's when I really started to learn more about public health and seeing that if you worked at that population or community level to put in place programs for promoting nutrition, physical activity, reducing smoking, road safety, you could actually reduce the burden on individuals, but you could also improve the quality of community life at the same time. And that's what drew me in, yeah.
So where did CIHI and your decision to be involved with CIHI fit in 17 years ago?
Yeah, so I've been involved with CIHI, certainly as a researcher, almost from when it was first created. And so I was involved in a number of projects with CIHI in its early days, particularly around the population health and public health side. I first came on as a board member, I think around 2009. And that was a period of time when, it was a few years after SARS had happened in Canada, and particularly hit Ontario hard. And so we were looking at how we could use health information better, again, to improve the health of the population, the delivery of public health services, and the perennial problem of getting timely information. And so that's really what drew me into being more involved in the governance of CIHI.
So when you look back at the scope of your career, what makes you most proud?
Being able to show the importance of benchmarking in looking at the quality of health services. And the reason why I'm proud is when this kind of work first started, it was criticized a lot.
Why was it criticized?
Because people didn't believe the data. They didn't want to believe the data. One of my earliest studies at the Institute for Clinical Evaluative Sciences was looking at patterns of surgery for breast cancer. And we showed huge variations across hospitals in Ontario. For breast conserving surgery, we showed that the pattern varied from 10% to 90%.
And this is where they would, if they had a woman with a small breast cancer, some physicians would remove it all anyway, or more of it, and some would do the least possible damage. So you were trying to bring order or some sort of consistency to medicine. And did you succeed?
Oh, yeah. And I would say, if we look at it, what's happened, the initial response was all the reasons why our data was wrong. And if you did have the more precise, the breast conserving surgery, you needed to have radiation afterwards to ensure that the cancer hadn't spread, to get the same outcomes as you would if you had mastectomy or the entire removal of the breast. And so if you didn't have access to radiation therapy, so you remember back in the early 90s, we had huge wait times for radiation therapy in Ontario and right across the country. Or if you lived in the north, where, again, at that time, there were very few radiation therapy sessions. So I would say it was also an important learning experience in the sense that you put out this data, you then have to understand why there's such large variances. And so that led to a whole program of research to look at why there are variances. And some women, older women, prefer to have the peace of mind that if they had the entire breast removed for that early stage breast cancer, they didn't have to worry about a recurrence in that breast. They didn't have to go for the radiation therapy. So we looked at what were those factors that were maybe based on the health system not having access to radiation, based on individual women's preferences. And once you took account of all of that, there were still large variations. So it was
that pointed to the doctors.
Yeah,
then.
It pointed to the communications. And so then we worked on providing decision support tools for surgeons to use with their patients. And it starts with the data. That's what CIHI is about, showing these variations. Then you use data and more research to inform what causes the variations. And then you say, how can we support people in making the right decisions? And then again, that requires lots of data, research from different epidemiological studies to support that kind of decision making.
It's interesting. You started as a clinician, but you're still having an effect on people's personal lives and their health.
Yeah, and now I sit at a university, and it's very interesting because Waterloo is a technology-oriented university, strong engineering, strong computer science. But one of the things that brought me here, and I've been really excited to work on, is a lot of the applications that people are working on in what I'll call the disruptive technologies, artificial intelligence, robotics, are actually in the health space. And many of the technologies are really focused on getting technologies, whether they're diagnostics or treatments, out into community settings, into remote settings, moving away from this model that you have to go to a specialized hospital to get services, and taking those technologies, miniaturizing them, using sensors remotely to bring them out to communities or to remote and rural communities. And so if we think of quantum sensors to do brain imaging, we're looking at smaller and smaller levels of resolution and generating more and more data about that individual. And we need technologies like AI to analyze all of that.
So I take it you're mostly excited by AI. The positives?
Well, the positive is that ultimately it will put even more ability for individuals to make the decisions for themselves, right? Imagine, and I'll give you a very concrete example. I saw this demo just a few weeks ago. Imagine you're a child with a complex condition, and the parent gets this PDF document. It's 60 pages of all the information that you need to take care of the child. You can drop it into this tool that actually exists. It's a Google tool that will take that 60-page document and turn it into a podcast like we're on. And you can say, make this appropriate for a 6-year-old.
Sounds amazing. Amazing. And they can listen to it.
You can listen to it, right? So that's just one example of the way in which we can really empower people to make the best decisions for themselves.
What worries you?
So there's a few things, obviously. One is AI models are only as good as the data you feed into it. So if there's mistakes in that PDF document and you feed that in, you're going to have those mistakes in the model as well. But more significantly, in healthcare, one of the things we worry about, if the data are biased, if certain communities haven't been included in the research that feeds the model, then the model is going to have those biases as well. But I would say we can't rule out using this technology because the potential for benefits are amazing.
Do you believe that public health is stronger than ever, or is it in danger?
I would just say public health is always in danger.
Why?
So, public health and prevention in general get maybe 3-4% of the overall investment. And I've heard this from politicians of all political stripes at all levels. They understand the importance of prevention. But what they'll also say is when they're campaigning and they're at the doorstep, if it's a question about health, it's why is my grandmother waiting months to get her hip replaced? Or my child needs to wait for hours when she's ill and we go to the emergency room. They'll say, I never get a question about why are there not more smoking cessation programs, or why is there not more investment in healthy eating? People know that fundamentally, but that's not top of mind when they go to the polls. And so I think that's what drives our political decision-making and leads to constant underinvestment in public health.
I'm Avis Favaro, and you're listening to my conversation with doctor and scientist Vivek Goel. After a short break, find out what he thinks are the biggest threats to public health in Canada.
Hi, I'm Kevin O'Keefe, host of CIHI's new webinar series, Beyond the Numbers. If you're enjoying Avis's conversation with Dr. Vivek Goel, I'd like to invite you to our next webinar, United We Stand, How Collective Impact Can Make Healthcare Better. Vivek will be joined by a number of experts examining how collective impact has the potential to revolutionize Canada's health system. So what is collective impact? It's a new collaborative way of working together to solve complex social challenges like poverty, education, and healthcare. You can register to attend the live webinar on Monday, July 7th from noon to 1 p.m. Eastern, or watch the recording after. All the information is at CIHI.ca. That's CIHI.ca.
So what are the biggest dangers or concerns for you as you look ahead at public health in Canada?
We worry about public health the most when we have a big infectious disease event, whether it's SARS or COVID, and globalization, global warming, deforestation. There's all these things happening in our ecology, which are bringing humans and animals closer together. So the current issues with bird flu. And so we're just going to have more and more of those. And our ability to detect those early, to control them. We're debating over an ostrich farm in BC right now. And there's obviously legitimate sides to that debate, but so the threats to public health are economic, but they're also social, right?
There's that difficulty, but there's also the issue of misinformation. So I bring up measles, which I always remember was something that we could eradicate. We do not have to have it. And yet now here it is, and it's growing. That to me is a sign of the threat to public health.
Absolutely. And that, again, ties in with what is happening, particularly in the United States, but right around the world. The decline in measles vaccine utilization has been going on for several decades, but the COVID experience and social media being able to drive misinformation and disinformation so quickly has really accelerated what we're seeing. And so we wind up having individuals trying to make choices in the face of that misinformation, disinformation. And the trust in public health has really been eroded over the last few years.
Do you see that? How do you see that?
We see that with declining confidence in public health officials, declining confidence in the direction that comes from them, and in declining support for public health from a political level.
COVID obviously was the biggest test. Were we prepared for that?
In some respects, we were prepared, but in many respects, not. And if we go back and look at all of the reviews done after SARS, if you go through all the recommendations and all the reports after SARS, I would hazard that less than half we would have really been confident had been met at the time that COVID hit. And so a good example was the need for a national immunization registry has been identified repeatedly, and again is being talked about as we're going through the measles outbreaks this year. And we had decisions made around adopting a system across the country. Its adoption was variable across the country. By the time we got to COVID, it could not do what was necessary to support the immunization program. So everyone was building systems from scratch to support the COVID vaccination programs. It's an example of something that we worked a lot on, but we failed to implement it in an adequate way to meet the needs of COVID.
Mm-hmm. So if you had to, from your position, whittle down the key pieces of advice to the next group handling the next pandemic, what would it be?
I would start with information, because when we talk about did some of our public health measures, the closures, the restrictions on gatherings go on too long, part of the problem was we didn't have the data to make informed decisions about which places were safe to open up and in real time. So knowing where infectious disease transmission events were occurring, where outbreaks were occurring, is critical for public health to be able to say, we should have restrictions in schools or in restaurants. But at a pan-Canadian level, we did not have consistent data about where those kinds of events were taking place.
You were part of a very, very big project to say, what were we missing during COVID? What do we need? Tell me about that.
Yeah, so that project really got initiated out of an agreement amongst the first ministers that was made in June of 2020. And it's quaint to think about it. It was called the Safe Restart Agreement because in June of 2020, about 3 months into COVID, we were thinking we were going to get everything restarted that fall. But one of the things in there was that we needed better data in order to restart safely. And so there was investments committed by the federal government in immediate improvements in data. But there was also one line in there which led to our work, which was, and let's develop a pan-Canadian health data strategy to ensure we don't wind up in the same situation for a future pandemic. And we started by looking at all the previous reports that have been done to look at health information in Canada and what we needed to do. And the first of those reports was actually from the 1960s.
Which said?
Which said we need better coordination, we need data standards, we need to deal with privacy issues. And pretty well every report over the next 60 years had similar recommendations.
What do you want to see happen, and is it happening?
We identified, first of all, what all the challenges were and why we failed to implement on these earlier reports. And then we actually said, you got to start with addressing those root problems. And so our recommendations centered around having better understanding of the importance of data, how you work with data. Because if you don't have that, you can't make informed decisions about how to implement data systems. Second thing is around the governance, how you make decisions around things like data standards, interoperability of systems.
Meaning the sharing of data.
The sharing of data in a pan-Canadian environment, like getting provincial ministries, healthcare organizations talking to each other, and collectively committing, if we're going to use this data standard, we're all going to do it, and we're going to hold each other to account. A third area that we spent quite a bit of time on, because one of the barriers that's cited quite often about sharing of data is privacy concern. That in sharing data, we might breach the privacy of individuals, or communities might get labeled as in inappropriate ways. And quite often the health privacy legislation is cited as leading to health information custodians withholding the sharing of data from others. And so we looked at that and we recommended we have to move from a model of health information custodians who are actually in legislation charged with keeping data confidential to health information stewards. You still have a stewardship responsibility to protect people's privacy, but you also have a responsibility to ensure that data is used in appropriate ways to improve the health of individuals, communities, and populations.
Are we getting there?
We're certainly moving in the right direction. And we did have a recommendation, first of all, for a vision and a charter for all Canadians on what they should be able to do with health data. That was adopted by the health ministers and they all agreed to it. At that pan-Canadian level, we're certainly making progress. Alberta has really made a lot of progress in moving towards a single health information system for the province where people can access their health information. The clinicians can see what's going on across different hospital sites. Quebec is moving in a similar direction. So we are starting to certainly see that movement, but I would say the progress is very slow.
It's still 6 out of 10 Canadians still don't have access to their own medical records.
Yeah. And even if when they do, it's fragmented, right? You have different portals for different organizations and labs, but the quality of the data and the ability to share data across systems is very limited. And that's what's really holding us back.
So now there's also the issue of who controls all this electronic public health data, because the hospitals from which CIHI gets this electronic information have programs which are owned by American companies. Is that a concern?
What's worrisome is whoever controls the data is able to set the terms of access, right? And so they can certainly charge you money to access the data that is being controlled, but they can also limit what it's used for. And so whether it's a large corporation, whether it's Canadian or American, I think we do have to really work on the regulatory framework that ensures that the uses, particularly for public health purposes, tracking the spread of infectious disease or monitoring the quality of programs, we need the right regulations in place. The previous government had introduced a piece of legislation about a year ago. There was a piece within it called the no data blocking regulation that would have prevented these private companies from blocking the use of data for appropriate purposes. That died when Parliament was prorogued, but it's going to be important for it to come back soon.
Public health has come a long way. I mean, if you just basically look at longevity, Canadians are living longer and generally better than ever. What would be your advice to the health leaders, to the new Prime Minister, about what the priorities should be when we're looking at organized health protection, which would be public health?
Yeah, it's a great time to really move forward on what I would say is the fundamental issue, and that is how do we do things across the country, across provinces and territories, so we can generate the information we need at that pan-Canadian level. And as we're talking about breaking down interprovincial trade barriers, right? This to me is just an example of another type of interprovincial trade barrier, because it's a barrier to the sharing of information that will lead to better health and outcomes for all Canadians, and will actually lead to economic outcomes as well.
What is the biggest lesson you've learned that you would like to share with the people who follow you?
Looking at COVID, we often looked at other countries that were ahead of us. So like during vaccines, Israel was getting vaccines pretty well in real time. And one of the reasons was that they were able to do a deal with Pfizer to do real-time data to monitor the effectiveness of the vaccine. And within a few weeks of starting their immunization campaign, they were able to use their population health information systems to generate vaccine efficacy data and publish it in the New England Journal of Medicine. We should be able to do that in Canada. That would be the vision I have for the future. You have to bring data together from so many different systems, and you have to have it at a large enough population size to have meaningful results. And if we were able to do that, because the data all exists in Canada, we're not able to bring it together. If we were able to do that, we would outshine any other jurisdiction in the world.
Do you have any regrets of things that you wanted to do that you couldn't?
Oh, there's so many.
Your biggest regret?
I do feel on the Pan-Canadian Health Data Strategy, we started it 5 years ago. I feel that I really wish we could have moved it along faster. So we're 5 years out. at the pace we're going, it's going to be many more years before we actually get to that vision I just described. And I do worry that in the meantime, the technology is going to continue to evolve around us. The private sector players are continuing to take a greater share of the data, and we will not have the ability to have access to or control of that data. And that's going to have meaningful consequences for the health of Canadians.
What are those consequences?
If we wind up with huge gaps in our data on the spread of disease, the outcomes from disease, then we're not going to be able to make meaningful decisions about where to target programs, how to improve those programs.
Does the politicization of public health concern you? We are seeing that in the United States, where a different agenda is looking at eliminating research, silencing universities, and that. Does that threat stretch to Canada?
Well, first of all, certainly what's happening in the United States is a threat to the world, right? Because the gutting of particularly the Centers for Disease Control, but also the National Institutes of Health and the Food and Drug Administration, those were bodies that generated research and data that informed actions of people around the world. And so that's gone. The withdrawal of the United States from the World Health Organization, which is now well underway, is going to have an impact. So that just on its own, even if the politics itself did not spread, is going to have serious consequences.
Do you think social media has played a role in this?
Yeah, because I think social media knows no boundaries, right? And especially for Canadians, it's very hard to distinguish if you're on the receiving end, the information you're getting, whether it's coming from someone in the United States or Canada. And so I think that will certainly continue to play a significant role as we continue to see erosion in trust in public health.
Do you ever lose sleep? You spent your whole career trying to build up public health, and now it's fraying.
Yeah, it is fraying. I'll again say the challenges that we're talking about were always there. They're amplified now, and misinformation can move around faster. But even if we go back to the early days of what we'll call modern public health, which was the sanitation movement in the early 2000s, the late 1900s, there were a lot of resistance to doing those sorts of things, right? Getting clean water, sanitation, when vaccines first came through. So every generation of public health has to fight. And I think some people would actually say all public health is politics. It's a political, right? Because it's organized. So you're always working at that policy and political level.
So despite the threats and pressures on public health, you're still hopeful. You're hopeful. You still have goals.
You have to be hopeful.
I repeat, you've had an incredible career, and you've had even the story about the breast cancer patients. I remember that study. That had an effect on people, and it led doctors in so many different directions.
That's right.
Yep.
Okay.
I want to thank you for your time, your reflections, your advice, your guidance.
Great, thanks.
All right.
Bye, Avis.
Thank you. While Dr. Goel is stepping back from his role at CIHI, he will continue to shepherd the work at Waterloo University and those healthcare innovations he talked about that may someday come to a clinic near you. And watch for an upcoming webinar with Dr. Goel, where he will talk about his work on an important new initiative. It's called Collective Impact. Intriguing, isn't it? That is on Monday, July 7th from noon to 1 p.m. Eastern Time. To find out more, go to CIHI.ca. Thank you so much for listening, and please subscribe to the podcast on your favorite player. I'm Avis Favaro. Talk to you next time.